So while Dr. Sipperstein gets set, and so our plan with Kristen, she doesn't need much filler, right? She's a good-looking, beautiful woman. And also, let me just say, that to Dr. Sipperstein's point earlier, this is an art. And if you want people to come back, they're there and they're opening their lives to you for you to tell them all the things that are wrong with them. So I try to always begin with a compliment. Dr. Sipperstein mentioned earlier that people start crying during a consult. People will come back 10 years later and say, remember when you told me I needed a facelift? So I always try to begin with a compliment. And so, saying, and not to be cheesy but to be real. You're a beautiful woman. You have a beautiful nose. You have a beautiful cheek. You want to compliment them and then say, and by the way, we need a little lift here, right? So all we thought for Miss Kristen is that if we could just lift her a little bit, it would help her facial shape. She's got a little bit of a squared off shape. She's got a little bit of a heavier lower face. So giving her a little mid-face volume and giving her a little bit of lift here is going to be great. And then also she's got a little bit of a nasojugal crease here, so we can try to first I start deeply, and then I fill it more superficially if it bothers them. And some people it's just their anatomy. And so let's just begin. Dr. Sipperstein, I'm just going to begin with some voluma in her cheek.
Sounds great. So we already went over some of those arteries. Maybe while you're getting set up, I can show again the facial artery going in and how tortuous it is and why we always get in trouble. Let's see. Can I have the side camera? Perfect. All right, so I'm going to pull out the facial artery here, going into the angular artery into the nasolabial folds and in the cheek. Now, I said it's very tortuous. Can you guys see this? Let's see. This little curly Q. It comes in and it goes out.
I don't use that, okay.
And then it comes more superficial all the way up into the cheek area. And it's coming up into some very small ones. But let's stay lateral on the cheek and see what else we have to look out for. So this is probably the plane she's going to be in, and you can see some nice fat without too many arteries. Are you going to be using a needle or a cannula?
I almost exclusively use cannula on my cheek, and I have a little different injection technique. So I want to encourage you to see a lot of people inject. I watched a lot of people, I gathered a lot of techniques, and so my cheek insertion point is a little different. It's a little higher. I use Chris Surik, who's someone that I also watched inject, and he's an anatomy specialist. I think that you find what feels comfortable to you. You try a few things. I used to do needle. I used to do cannula coming up from below, but then I was fighting the zygomatico-cutaneous ligaments every time, and then hoping that I wasn't popping through the orbital retaining ligament. So what I do now is I take the mid-zygoma, and I know that the zygoma is going to have sort of a curve here. I can be flat this way and then flat going lateral along the zygoma. So my injection technique and my cannula insertion point is to take this zygoma, pinch it in between my fingers at the point where I think it's making its biggest angle, so that then I don't have to fight the curvature. So then I will use the insertion needle to just get through the skin. Like Dr. Sipperstein talked about, we do have a transverse facial. We've got some vessels we don't want to get into. I use that to just get through, and then I'm ready. And then what I like to do, which is, I know this is different than some people, is I like to take my cannula, and I actually like to go 90 degrees perpendicular, get to bone and tap bone. So I know that I am on zygoma here. I know sometimes it's a little bit trickier to get all the way to bone. You gotta sometimes pass through orbicularis, but then I'm gonna support with my non-dominant hand, my non-injecting hand, and this is where she was a little bit low. So I know that I'm on bone, and what I'm gonna do is now pass this cannula, and I'm deep, I'm scraping the bone. To say you're in the prezygomatic space is a dream. The fat is very adherent to bone there. You're probably in the fat right above that prezygomatic space. And maybe Dr. Sipperstein can show us that. So what I like to do is, like I said, I come in, I feel the bone, I know I'm exactly where I want to be, I slide along bone, and I'm just going to give her, she doesn't need much. I'm just going to give her 0.1 or 0.2, and we're going to see, and sure enough we did, we delivered that filler, and we got rid of her little deficit there in the mid-cheek with a deep filler, no risk. I'm not going to get any festooning. I'm not going in over that malar pad. And then I'll do the same thing. So sometimes I won't come all the way out, but now I want to go laterally, and I want to be deep here. I want to be along bone, but I'm going to be fighting. This is a little bit of a harder injection, but instead of doing needle, which I used to do here now, I come up and I'm just going to create this lift on her cheek along zygoma. And also another great point here is my cannula is moving constantly. I'm not bolusing. If I'm pushing filler, I'm moving my cannula on. So this is to get that lift, and I'm fanning. And so we came in and we gave her a little bit of lateral cheek lift from the one injection point, knowing that we're on bone, and that's how I do my cheek filler.
Excellent. And what I would recommend you, especially in an elderly patient, is kind of mark out the malar mound here. You can see it in my patient a little bit better than you can see it in hers, because I want you guys to realize that if I am doing a cheek injection and I am past that area, I'm really doing an under eye injection. And so when my patients have the under eye swelling and I said, have you had under eye filler? They say no. The next question is, have you had cheek filler? Because if you're injecting on the bone right here along the cheek, that's technically an under eye filler. So just to be careful, I do the same thing as Dr. Jackson, where I call it, it's my analogy, an elevator shaft with my needle, and then I go in and I can get, with my cannula, I can get off at any floor I want. So you don't have to actually, you really just have to get through the skin, as she said, with the insertion point, and then if you want to be subdermal, I am immediately going over versus going all the way down, as she said, and then going over.
So I just want to point out that with that one injection point, it's too bad we didn't look at her in this plane before, but I want to point out her jowling and her jowling here, because we put in a good bit of filler lateral to the line of ligaments. So, and this is debatable, Dr. Sipperstein, but I do feel that whenever you're lateral to the line of ligaments, you're going to get more lifting. When you're medial to the line of ligaments, your focus is on filling. So we gave her a little bit of fill, but I gave the majority of the syringe, 0.7 was out here laterally, and look at her jowling. That's what they want, right? They want a gentle lift, a gentle help, but not necessarily look too full. So I just wanted to point that out before we inject the second side.
So they do have a publication on this, and I hear the for and against people use the same publication for justification, because the amount of lift they got was about like 1 millimeter or so, and so yes, it lifts, but is it clinically perceptible to most? Probably not. So again, it just goes back to underselling and over delivering. With my injection point for the cheek, most of my patients are older, and I'm trying to go around this malar mound, and so I tend to have 2 different insertion points. I tend, with my cannula, to do one here, and then they have that malar mound, and my patients have loss of this lateral fat pad here, and so I tend to then do a second one in the back there. But there's no right or wrong way. There's also, sometimes they teach coming from the back forward. It creates a very model-esque striking line, but the negative is you're kind of through the hair and you're not watching what you're doing because you're coming from the back forward. I always like watching as I'm injecting, so I'm not missing if I do have a VO and it turns white. I'm not missing if I'm overfilling.